out of the way. Okay. So what I'm going to talk about, the title is state variation, but what really I'm going to focus on here is on inference and how the state variation that we've been talking about, this big theme throughout the TAF data, how it fits into our inference. So just a minute. Just to remind you that this is a federal-state partnership, and because of the state part of it, we see much state-to-state and annual variation. So as states, and I'm sure if you think about your own state government, they will make changes to the Medicaid program at different times, and they'll make different changes based on budget consideration and need. And so the combination of the federal guidelines and the federal approval process with state programming and local control results in some differences, some interesting differences that frankly we're just not used to with the Medicare program. And so in that way, what it means is as we're designing our study and thinking about using our study and thinking about taking advantage of this big laboratory. So if you think about Medicaid, I mean, the biggest opportunity is we have this laboratory to try innovation and to try different approaches to problems and to see what works. But a lot of that depends on actually knowing what you see and what you don't see, and being confident that you're not doing like apples to kumquats variation studies. So what it means and what we're going to talk about a little bit today is really much more conceptual about how do you consider all the sources of variation and how do you select your population and define your variables so that you can be relatively confident in what you're seeing. And this, it can be comparing two states, or it can be comparing a single state over time, or some combination of things. So just as a reminder, there are statutory, and then move out of the way, I don't know if you can see that, there's statutory and regulatory required services with the Medicaid program. So every state is required to have this list of services. This is a MACPAC report. And you can see that there's a long list of things that every state has to have. But states also can create benefit packages within federal guidelines. So if you look at this, these are all state options. What I've done here to sort of draw your attention to things is the services that are underlined are ones where states have created benefit packages, where all states or all but one state. There's 51, just a reminder, is DC. So prescription drugs, under services for people under age 21 in an institution, prosthetic devices, home health services, optometry. Every state has done something. And yet there are other services, such as services furnished in a religious non-medical healthcare institution, where 9 states have. So this can be really helpful to understand how the states vary. But if you notice, a lot of these are somewhere in the middle. Emergency dental service, where 18 states have created benefit packages. So as you're thinking about the states, really trying to come to some understanding of how the state compares, or whether this is common or not common, is going to be really important. States also vary in their use of risk-based managed care organizations. We've talked about this. And if you can look from the dark blue, where more than 90% of the beneficiaries are enrolled in a managed care organization, to 12 states where in 2016, there were no managed care organizations. But also a reminder that managed care organization does not necessarily mean comprehensive managed care. So for example, you could be dark blue when all you had was 100% of your people in a dental managed care organization. So we both have differences in what percentage of beneficiaries are enrolled in a managed care organization, and not shown in this slide is how comprehensive those organizations are. So as we said, this is a federal-state partnership, and we're not going to go through this. Again, this is a MACPAC report that you can look at, but just a reminder that there are both statutory and regulatory requirements, and there are state plan options. And what you need to do when looking at your comparison or tracking something over time is understanding how those two line up. So again, the state option is where we get this innovation laboratory. So for health policy researchers, for people interested in helping low-income people, for people looking at disabled, this is very, very exciting, but it's also very, very challenging. Spending varies across states, and I just want to point this out. So when we look at spending, for example, I'm from Minnesota, and Minnesota is one of the dark blue states, the 15 states where the spending in 2014 per enrollee was in the top tier, where the lightest colored states, Nevada and Colorado, 7 states, so what else? New Jersey, Florida, had some of the lowest spending per enrollee. So you can see that there are differences in spending, which are of tremendous policy interest, right? So we want to know, well, why is it, and do you get, for example, the Minnesota-Florida comparison is one that in my career I've been watching since the mid-90s, and it's been a constant question of, is there a benefit of a high spending state like Minnesota over a low spending state like Florida, and what do you get? And in fact, does it translate to health improvements? States also vary in terms of their eligibility. So the income eligibility level for parents of dependent children, and again, you can see the dark blue states, it's less than 50% of poverty level, and the lightest blue states, it's at 138% of federal poverty level. So we can see that how broad the eligibility level is will result in changes, and it may result in differences in observed healthcare need or health behaviors as the income level gets higher. And so our question that we will always face is, so how do we actually compare Minnesota and Florida when we look at all of these different things that are going on? Income eligibility, and I want to point for parents of dependent children. And if you look at this is 2019, and look at the darkest blue. So this is at 138% of the federal poverty level, and look at how dark it has gotten. And I'm going to, again, as Steph would say, hope you don't get dizzy compared to last time with the dark blue. So I will point out one that Kaiser reversed the colors just to make it confusing, and we did not regraph these, but you will see the patterns shifted over a 5-year period. So we can see changes in state policy, and we've got to ask ourselves, like, what do we, so a very, very reasonable question would be, to me at least, would be, what happened when a state shifted their policy, when they changed the eligibility, and what did this result in, and how do we understand it in terms of not just cost, but in fact, ultimately health? We've talked earlier, Nate talked about Section 1115 waivers. Reminder, these give states additional flexibility to design and improve their programs. They're experimental, pilot, or demonstration projects that are likely to assist in promoting the objectives of the Medicaid program. They are subject to a case-by-case review, and they must be, quote, budget neutral to the federal government. So these are the waiver projects, and these are, again, a very interesting question of, are these waivers important, and do we see some that are really, that in fact result in meaningful change that ought to be expanded? And if we look at this, there are waivers. This is September 2020, and you can see the waivers. You can see the approved waivers. There's states with approved waivers, which are the lightest blue, the approved and pending, which is sort of the medium blue. There are a couple in the sort of dark blue, almost, but not approved and set aside by court, such as Michigan, and there are pending waivers in, for example, South Dakota. So, and then there are no waivers in 4 states. So you can see, again, the waiver status is interesting, and the question of how the states use waivers are both the specific waivers and perhaps as an indication of how creative the state is in managing their programming. This again shows as a different way, again, also from Kaiser, of showing the different waivers and where they are. We see that a lot of them are behavioral health. This is the most common. Long-term care services is another source of waivers. Work requirements has a lot pending. So again, the waivers vary by where they are, what they are focused on, and whether they're approved, pending, or set aside. And again, think of the other piece that we see changing by state is continuous enrollment. And we worry about continuous enrollment as health services researchers or as epidemiologists, because what we worry about is people disappearing and reappearing. And so that causes trouble when we're trying to do things like understand disease incidence and prevalence, and trying to understand services and services received, where we have these gaps, these interval censoring, if you will, and what happens to them. But one of the things that we see is that states vary quite a bit in terms of continuous enrollment. Colorado has about 3/4 that have at least 12 months continuous enrollment. Florida and Illinois have above 80%. So even within this range, the question is, what inference do we draw from these differences? To me, I always see these as a signal of state programming and state commitment to keeping the Medicaid population stable. There certainly are reasons to believe that stable coverage is preferable to unstable coverage. So when people come back, what we expect is we might see some pent-up demand from when there were gaps. But again, understanding that and looking at that and trying to figure out whether gaps will cause you trouble for your study design, and whether it will you'll start to lose generalizability will become a big issue, particularly as you're looking at something that's more than cross-sectional and is going to span some period of time, in this case, 12 months. States also vary in the underlying populations they serve. So for percentage of births, 71% of New Mexico births are covered by the Medicaid program and 20% in Vermont. We can ask two questions of, is this a reflection of New Mexico's Medicaid program or New Mexico's poverty level? But what it does mean is the utility and the importance of Medicaid in taking care of newborns is going to vary dramatically across states. And so as we talk about the inference that we can draw from these programs, we do need to take this underlying population into account. Another point is that opioid use is a nationwide problem. The size of the problem and how it's handled will vary by state. So again, if you're looking at opioid use, do think about the states you select and how you're going to find them and what you're going to find about them. There's also tremendous variation in healthcare use across geography. This is not new. For those of you who've seen the Dartmouth Atlas, for example, as I pointed out, the Minnesota-Florida difference, the differences in healthcare use by geography are likely caused by a range of things, and in Medicaid even more. So first of all, we definitely know there are practice pattern differences. Jack Wenberg from Dartmouth used to talk about high variation and low variation conditions. And what he was really talking about there is that practice patterns, including the supply of specialists versus generalists, will affect patterns. There also are local cultural differences around expectations around care for consumers, and those will vary not just by state, but in fact by small geographic areas within states. And there are variations in local economies. In other words, health status and insurance benefits will affect healthcare use. So these are all stacked on top of everything else with the Medicaid program, and we need to take those into account when we analyze and think about what conclusions we can draw. We also have, just to make this totally fun, state eligibility. So this is, for example, data quality. So these are the DQ atlases, the data quality atlases that CMS has created. You can find a link to them either from CMS's website or from ResDAC. And what they do is they identify states with different levels of data quality concern. And you'll see, for example, there is variation from the green with low concern to the orange with high concern. This is, for example, a table around eligibility group code for the first release in 2018. So you can see that states will vary in terms of level of concern or data quality. So and you can look up variable by variable. So if there's a variable that is particularly important to you or your question, one of the things we strongly encourage you to do is to go to the data DQ Atlas and look up that variable and make sure you are strategic when picking out which states you're going to use. So simply stated, if I were using eligibility group code as one of my key variables, I would look very carefully and consider which states I wanted to include. This is around race ethnicity code. And again, you can see much more variation than around eligibility code, but you can also say if race is a key variable of mine, I'm going to want to look at those atlases and look at that report and understand what the nature of this coding is and why is it that Rhode Island, Tennessee, and Mississippi are all coded as one, and does that coding and does that level of concern cause me to worry that if I include those states that I'm going to lead to the wrong conclusion. So again, there are no simple answers, there are no guarantees, but it's really about doing your homework before you get your data rather than figuring out after the fact. So other people have suggested that there's things called cash assistance, Medicaid only, fee-for-service beneficiaries with disabilities, and I don't know if CAMOD is pronounced or if it's CAMOD. And so this is this idea of like, oh, we can actually get a group that is exactly the same across states. The problem is that the percentage of people who are in this category may be very, very small, so that yes, we can compare. So it's Medicaid only, it isn't dual eligible, we will get a complete view of utilization and expenditures, restricting to fee-for-service, eliminates incomplete information. But what you are going to have to ask is, are we actually looking at 1% of the people? Is this in fact a reasonable group to study, or are we in fact sacrificing other things by trying to get comparability? And this is the dance that we have with Medicaid. I don't want to say it's fun. It's a very different challenge. And I know Nathan has talked about it, and we'll talk about it some more, as will Steph and Kendra. But these are the things that are essential to do. So I would say that the big thing to remember is that there's a lot more homework to do before ordering during the design phase with the Medicaid data than there might be with the Medicare. So in fact, this you can see with the CAMOD by hospital referral region, you can see in fact that there is variation in Florida, Texas, New York, Illinois in terms of spending. So this might be useful. Other people have certainly published it, but you're going to have to look into it and see if this is going to work for you. There's also variation in payments to providers. Often federal requirements generally cap payments for fee-for-service Medicaid at the Medicare level. So typically the Medicare payments may be used as upper limits, but as a reminder, states do have discretion over payment design, and some of that payment design might be very, very interesting to understand, or to take a state that has instituted payment design from one year to the next to understand the implications of those payment changes on patterns of care. There is definitely variation across states in the basis of inpatient hospital payments, whether they use DRGs, a per diem, or cost-based. And there are two ways I encourage you to think about this. I better watch the time. One way is if you want to know how they were paid. But the other question is if you want to know what they were paid. So in some cases, I've got friends who have cared very much about trying to predict what exactly was the payment and how did we know that it happened. But other people might want to ask the question of, does a DRG-based payment versus cost-based payment, or does the use of supplemental payments like the DISH, the disproportionate share, or incentive payments, do those change quality? So think about these and think about them both as a source of variation you might want to worry about, or perhaps an opportunity for inference and study. So just to summarize, the states vary in every possible way they could vary and over time in terms of the eligibility groups, in terms of how they support and verify continuous enrollment and eligibility, in terms of their use of expansion programs, and how they use managed care. So this is challenging in a way that you will not typically see, but it also means there's opportunity in a way that we don't always see. So again, if we look at the spending across states and we think, what is it that could be driving this? We've got to recognize that there are any number of things, and it may not just be purely budgets, but it may be other levels of control. And we need to understand that if we're going to actually make sense of this map. So just, from my perspective, variation is a researcher's dream. It's where we find things. If there's no variation, there's nothing exciting. But the challenge is that we have to understand the origin of the variation, because that's going to be our nightmare, is not taking the time to think about it and to try to understand it. So even for us, for example, as an epidemiologist, putting on that hat, I could say, well, I'm not an economist. I don't care about money. I'm not a policy person. But in fact, even for somebody who might say they don't care about it, you really have to take the time to dig into state policy, to understand the nuances of eligibility groups, managed care, data quality, the population, the healthcare use, and all of that, and to make sure you understand how it varies state by state and over time during the design. And so with that, both, again, I would argue an opportunity and very much of a challenge. Are there any questions?
So there were just a couple questions about the DQ Atlas, and we've got links posted in the chat if anyone's interested in looking at that. We'll also have a chance during the exercise to look at that. I think that's all I've seen. Does anybody else have questions? It's right before lunch, so we may have hit our wall at this point.
Yes. Well, in that case, thank you all very much. We'll start lunch. We'll give you 7 minutes back, at least according to my phone. And please don't hesitate to reach out for something in the chat if you've got other questions. And I think this should set us up well for the rest of